Thanks, Liz. Okay, welcome everybody. It's our December meeting for PHAB, last meeting of the year. Hope everybody's well and had a wonderful Thanksgiving. I want to start by welcoming everybody, and I think we did some introductions last time, so I'm going to save this one for an introduction for a new member that we have, which is just wonderful. And Sarah has joined us. This is Sarah Bowski. Thrilled to have you on. Thank you. Sarah, do you want to just introduce yourself a little bit and say perhaps a little bit about your background?
Sure. Well, thank you, Farley. And she's a great ambassadoress for this group, by the way, as you all may know. My name is Sarah Bowski, and I am I've been working in international public health for over 30 years now. I've focused on HIV, started in Southern Africa, spent about half of that 30 in residence, split between Lesotho and Mozambique. And have worked for the US government, for USAID. I've worked for large nonprofits and small ones. And then, the last 20 months, like everybody else, we all got pulled into COVID. So I've been actively engaged in that internationally. Currently, I backstop a $200 million infectious disease program for an organization based out of Washington. And I really, I'm a nurse and I volunteer on the side of vaccine clinics and help on strategies and do all kinds of other pieces of also domestic related work for our organization. But really, I came from California. I grew up in Davis, left for more than 30 years, came back, and now I'm in Sacramento, and really was just seeking an opportunity to be able to give back a bit of sort of what I've learned and see where I can't be of service to the community that I live in. So I come with all kinds of other areas of interest and skill, but I'm really looking forward to getting to know people in this group. And I sat in on the last meeting and was really impressed and have done quite a bit of reading. And so I look forward to being of service. Thanks.
So welcome again. That's great. A wonderful addition to our incredible board. So just want to let you know that we have a loss of the board. Emmanuel, who has been a terrific member for a long time, had taken a new position. He's the head of a transplant team. He's a coordinator and a busy man, dad. And so he was trying very hard to juggle everything and to stay on the board, but has found that it's just not doing, he felt it wasn't doing the board service. So he has resigned. And so we have another vacancy. And I want to let you know that Tina has taken another position, which is terrific for her and a loss for us because it's in Colorado, and that kind of doesn't qualify for her to serve on the board. So she'll be leaving. This will be her last meeting, I guess, if she's joining. I don't see her on yet, but she's been just an incredible force on the board. And a lot of times we don't see what the members do necessarily, because if it's more involvement on the executive committee, then the whole board doesn't really see the back end of things. But she's been terrific. And she has served as our vice chair. So I'm hoping she'll join. But she also will be resigning. There is an interview with another candidate next week, so I'm hopeful that that will be a fruitful meeting, and that the nomination, if the chief deem it, it will go to the Board of Supervisors. I guess it goes to them and they decide if they're going to nominate the person to sit on the board. So I'll keep you up to date on that, but that's another prospect. And otherwise, we have ourselves and we're pretty good. I think everybody on here is wonderful. And thank you again for your service. Hi, Barbie. Let me see. So we also have a couple of vacancies if anybody wants to sit on another board. So let me know. We talked about it a while ago. The first 5 is a board that needs our representation as also the Human Services Coordinating Council. So if anybody's interested, I can give you more information. Just reach out to me. Otherwise, I want to let you know that I think you saw the email. PHAB got an award, and I'm sorry I can't see this. This is our certificate, and it reads that the Greater Sacramento Smoke and Tobacco Free Coalition hereby recognizes the Sacramento County Public Health Advisory Board for embracing the change to the coalition structure and for their continued support of the mission and goals of the coalition. So I attended their ceremony. It was very impressive. They've done so much work and given out a lot of awards. And that's really nice. So I will send that to the county and somebody there will hold on to it for PHAB, but congratulations. All right, so from here, I think we will head over to the public health division update. And Sandy?
Sure. I can start. I'm hearing an echo. I'm not sure what's causing it. So hi, everyone. Real quick.
Oh, sorry. It was switched again. Okay. Hi, Olivia, Dr. Cassirier. Okay, go for it. We hear you.
Okay. All right. Real quick, by way of update, our case rate is at about 8 per 100,000. If you recall, we set a goal or a target for 5 per 100,000 in order to end our masking mandate. And so we are still sticking with that. We don't know whether the reduction, though, in the case rate might be an artifact of reduced testing during the holidays. So we will continue to monitor for this week and see what happens. One major piece of news that just came through is that California did identify one case of the Omicron variant in San Francisco. This was someone returning from South Africa, is on isolation, mild symptoms. But I think this is something that everyone has been saying, that it was just a matter of time that, we'll start identifying it. There's still a lot that's not known. It's expected that this variant is either as transmissible or more transmissible than the Delta variant, but those are all things that we'll find out soon. So far, it seems like all the people that have been infected have had mild symptoms, but also we do need to note that all the ones that have been infected so far are young people. So we don't know what the impact will be if it does get to the older generation. I think those are all things that we're finding out, also waiting to see. There are studies being done to see how effective the vaccine is against this new variant. It is expected that it will have some effect. I think it's just a matter of how much of an effect that will be. So still pushing for everyone to get the booster dose if they already got their first series, or to go ahead and get their first and second series. We're still slowly trickling upwards in our number of people that are vaccinated. I think we're at like 59 point something% right now. So continuing to work on that. We do have reduced resources right now. And so doing the best that we can with the resources that we have. We are hearing anecdotal reports that people are having a little bit of a harder time getting appointments. It's not because of a lack of vaccine. I think it's just a limit of the appointments that are available. So we're just telling folks, hey, just take the first slot that you're able to get. And this is true for pharmacies or for the major health systems as well. But we'll continue to monitor, and if needed, we can work with our partners to set up additional clinics for booster doses. Vaccinations for children are going well. It seems like we are getting a good uptake, but still have a long way to go in getting everyone vaccinated. One last thing is that yesterday the FDA approved a new pill for treatment of COVID-19. There will be limited supply of the pill. So we are in the process of working with CDPH to find out where the pills are going to go and criteria for who will get the prescriptions. The advantage of the pill, of course, is that it will allow treatment at home. Right now, the treatments that we have, the monoclonal antibodies, do require a clinical hospital visit. So it has limited the ability to have it available for everybody who needs it. So having a pill will also help with our efforts to fight COVID-19. Those are the major updates. And I see a question from Steve. Yes, we are still, with our pop-up clinics, we are still focusing mainly on what we call our health equity zip codes, mainly in North Highlands, but also in other areas as well. But again, then our capacity for being able to do pop-up clinics has reduced. So there are not as many clinics available as we had earlier on. I'll turn it back to you.
Are there any other questions for Dr. K? Okay, the question of limited resources is from staffing.
For
You were talking about the vaccination effort.
yes, we do have limited staff. Nurses right now are at a high premium, not only in the hospital settings, but also for public health. So we're still trying to hire additional nurses to be able to assist, but it's taking quite a while.
Yeah. It doesn't seem like that's going to get better anytime soon, right? No. Okay. Thank you so much. Okay, now, Dr. Damiano, for an update for primary health.
This is Sandy Damiano. Can you hear me?
Yes.
Okay, I lost my video. I lost Zoom, so I had to call in. So I apologize. I can't even see anybody or the screen. Liz, if you don't mind putting up that PHAB report online so that people can follow the numbers, that would be great. And the numbers will be in your minutes. And I'm going to do basically a COVID report since we're in the outbreak. For juvenile correctional health for the period of 11/21 through 27, they've had 61 cases throughout the pandemic. They only had 7 tests last week and no new cases. Their census is starting to get a little higher. It was 123, and they're having more people from the 19 to 24 age bracket. For their vaccinations, those have been pretty stable at 87. The team is going to try to problem solve to see what else they can do to engage the residents in getting vaccinated. Please jump in if I go too fast also. For adult correctional health, our last dashboard was right before Thanksgiving. You can see we did about little over 448 tests. We had a net increase of 36 new cases for the week. And we are going down in terms of the numbers of cases. If you could try to put on board the data report on page 3, which actually shows the cases that are in custody for the main jail and branch jail, Liz.
Yep, 1 second.
Okay, so people can see the curve going down, and we are getting ready to put a dashboard out for this week, which should be posted on the sheriff's website, hopefully by tomorrow. Our net new cases from last week till today are a net increase of 21. So they are kind of going down. It's at a slow rate. It's still at the branch jail. Main jail has been stabilized since mid-November with only new cases coming through intake period. So back to my other report, we're able to contain this outbreak and mitigate the effects more quickly than last time. I think because we had protocol in place and we were able to notice when the outbreak was happening, we were able to intervene more early. We have been meeting multiple meetings with the Sheriff's Department frequently, but at least weekly. We've also been meeting with Dr. Kasiri and her team weekly to review the data and efforts. And then now I have a nursing director also meeting with public health and state public health on this outbreak. So we're getting really good consultation and our numbers are going down, which is encouraging. For the inmate vaccinations, if you can flip over to the second page of the report, that is going far slower. We had a net increase of only 38 inmates last week. I've asked the captains and also nursing to look at what else besides the financial incentive can we do to incentivize inmates to get the vaccination. And you can see the point in time data for the inmate vaccination. It's about the same. 30% had at least one vaccination, 27% fully vaccinated, and that's because of the high churn rate. Most of the people who have been vaccinated have been in custody for a long time. You can see our staff vaccination rate is excellent. 95% for medical and admin that are on site, 90% for registry and contractors, and mental health is 97. So we're not really having any COVID infections at all from our medical or mental health staff during this outbreak period. Okay, and then what I don't report on is the number of tests that happen every week. We do, through public health, actually puts on the testing clinics for staff as part of the state mandate. And Liz provides that data for me weekly, which I do share with the command staff. And those are for staff who are unvaccinated and for inmate workers. Then the last bit of information, I know the PHAB working group was talking about our vacancy rate. And so I did put a little blurb in for a point in time of our current vacancies. You could see we have 38 for medical and administrative and 23 for mental health. We're just having a really difficult time with recruiting and attracting quality candidates for positions. I'll pause there and see if anyone has any questions.
Wow. Sandy, there was a question from Liz Blum, a public comment.
Okay.
In the chat, it says, I'm still hearing from dozens of people inside the jails that cleaning supplies are not being made available, which seems especially important for people who are in quarantine dorms in RCCC.
In the branch jail.
Yeah.
I can send that message to the commander and I'll be happy to do that. I have heard different from that, but I can, this was recently, Liz, that you've heard this?
Yeah, I get calls almost daily, and yeah, would appreciate you passing that along. Thank you.
I will for the captain and the lieutenant, the assistant commander. Thank you.
Libby, you have a question?
Yeah, thanks, Dr. Damiano, for the update. And I appreciate you adding the staffing picture. I think that's super helpful. You've spoken about this before. I know you guys have done some work, I think, to make the remuneration more competitive, but I'm just curious, like, since this is such a persistent challenge for you and you have so many open positions, sort of what are there any other strategies that you guys are brainstorming to try to bring in? Like, what can you do to solve some of those gaps?
Yeah, it's really tough. At UC Davis, which is the mental health staff, they have very competitive rates, and they are still having difficulty. I think it's because all health providers are recruiting, and I know in meetings with hospitals, they've also had difficulties with nursing. So part of our nursing equity is not effective till January. I think that's going to really help a lot. With our physicians, what we are looking at, we're getting a lot of interest from part-time, but we really want some full-time people as well. So we're looking at what else can we do to advertise or reach out for the physician staff on that one. There is one other union, or actually I think two more, that we'll be looking at entering into labor negotiations in the new year. So it's going to be a concerted effort, you're correct. And then when you have a consent decree going on and you have space issues, that doesn't bode well for attracting candidates either.
Yeah, sounds very tricky, but helpful to hear about some of the initiatives.
Correct.
Thanks.
Yeah, well, it is good to know. I heard from outside somebody who saw the posting about, I guess it's psychiatric posts, psychiatrists, that the salaries look very competitive, which is a step forward. That's great. Yeah. Any other questions? Okay. And I echo that I appreciate the addition of the vacancy list on the dashboard. That's for our purposes. Thank you.
Okay, you're welcome. I'm going to try to see if I can get back into the actual meeting. Thank you.
Okay, great. So I was waiting to take a vote on the minutes for everybody to join, and so I skipped over that, and we can go back to it. I know there were a couple of comments and corrections to be made that Sandy noted, and those will be included. Are there any other corrections that people have for the November meeting minutes? Before
one that I noticed, this is Steve. My formal full name is Stephen with a PH. Dr. Orkan misspells his name.
We'll have to talk to him about that.
Right.
Okay, we will change that.
Thank you. With that change, I'd move approval as modified.
Thank you. Great. Any other changes before I accept approval? No. Okay. Any seconds on the motion?
Second.
Thank you, Libby. Okay, so could you enter in the chat your vote on whether you accept or not the minutes as noted and corrected? And I'll vote aye. And you can vote anything that works. Okay. 1, 2, 3, 4, 5. Any nays, if anybody has a nay? No. Okay, minutes are approved. Thank you very much. All right, we will now proceed to the rest of the meeting. And we're going to have a vote, hopefully a quick vote. We coming to the end of the year, and at the end of the year, the terms for officers for PHAB expire. So we have to do this again and see who would like to serve on the executive committee. I didn't receive any nominations by mail, but I will put forth some nominations. Does anybody else at this point want to nominate anybody for either the chair position, the vice chair, or the 3 other executive committee members? So just think on that for a moment. I'm going to put forward Larissa May, who's been serving as an executive member this year for most of this year, I believe. Phil Summers, Cinahl, and Libby Abbott, and I guess myself. And I'm going to nominate also Cinahl to be vice chair, as Tina will be resigning. Does anybody want to add to that?
Carla, for that list, you were nominating them, you're putting them forward for what?
Well, Cinahl will be vice chair, and Larissa, Phil, and Libby will be executive members. And unless somebody wants to take the chair position, it's open. Another nomination can come in at any time. But if I hear none, I guess I will put myself forward for the chair position. And as noted, you can nominate yourself, anybody. Okay, well, so I guess hearing none, going once, going twice. Okay, so let's try and take this one at a time then. So for the chair position, could you vote yay or nay, or whatever you'd like to designate, whether you support myself as chair for another year? And then I term out.
Farley, do you want to send them to somebody who's not everyone?
I'm sorry?
I mean, do you want them to be a public vote, then an open vote?
It has to be.
Liz. Oh, okay. It doesn't go to Liz.
No, it has to be, everything we do because of the Brown Act has to be open.
Okay.
Unfortunately. And, you know, there's a reason for that, but I know it causes some problems. All right, so let me just try and open this chat a little further so I can see what votes came in. And Liz, if you want to count 2, 1, 2, 3.
We have 9.
Okay.
Have you voted, Carla?
No, I haven't. I'm waiting.
Okay, and it's 9, including yourself.
Okay. All right. So I guess I'm into this for another year. Just thank you. And I'd like to rope in Cinahl. So can we vote for Cinahl as a vice chair on the executive committee?
Carla, I think we're missing some votes.
Oh, are there any? Oh, I'm sorry. Yeah, that's true. We have more people here. Anybody who would like to?
12.
I'm sorry. Yeah. So if you're, whatever your vote is, either an aye or a nay or an abstention, please enter that into the chat. Did we lose people? Anybody? Let me see.
It looks like I don't have a vote from Melinda.
We don't have, Melinda's not a voting member.
Oh, sorry about that. Sarah Bowski.
Sarah,
I can't vote until, I can't vote until they provide me with the opportunity to complete Form 700.
Oh, yeah, that was the
Thank
issue.
you.
Yeah, so I'm still waiting for that form, and then I'm happy to vote.
Okay, I'll ding them.
And I think Jofel.
Jofel might have been pulled into another meeting, although he's still here. So, all right. Well, as long as we have a majority of 7, we're good. The majority of the members. So we do, so we'll just continue then. All right. So going back to Cinahl, I hope you know what you're getting into now. I'm kidding. So please enter, enter your votes into the chat, whether it's a, nay, or abstention. And then we'll. Oh, and Joe Phil did weigh in. Good, thank you. So 1, 2, 3, 4, 5, 6, 7. Great. Congratulations, Cinahl. You are now officially vice chair.
Thank you, Farla. Happy to work with you and the rest of the team. Continue to work with all of you.
That's
Congratulations.
All right, Larissa, who's been serving on the board, very, very glad to have her on the board. Very wonderful board members. So again, I nominate her and we can vote on her appointment. Oh, where did it go? Okay. Everyone. Yeah, all right. So please enter your votes. Yeah, great. Thank you, Steve, for noting those as well. And so now it's very helpful. 1, 2, 3. Okay, Larissa, we get you for another year. Terrific. And finally, I think it's Phil. No, 2 more. Phil, so Phil Summers has been on. Again, let's vote in the same way for his appointment. Yes, you can vote for yourself. Yes, you can. Okay, wonderful. Terrific. And one last appointment, and that is Libby Abbott. Libby, our co-chair with Phil of the working committee, has done an incredible job. And so we vote for Libby as a new member on the committee. Terrific. All right, so we have enough votes for confirmation of everybody. Welcome again to the committee, or anew, and thank you all for this. The committee does great work, and anybody can attend the executive board meetings anytime you want. So please indulge in that if you would like. And so for another year, here we go. Next, on to more interesting, possibly stuff. So we have back Stacy Sayers, and thank you very much. I know this might not have been a very convenient time for you, but definitely appreciate you attending again. And we're looking forward to a lot of good information and good discussion. So if Liz brings up your presentation, I guess we can take it away. How are you feeling, Stacy? You doing okay? I mean, are you muted? I can't see that.
Oh, I'm sorry. Yes, I'm fine. I apologize. I didn't realize I was muted.
No.
Liz, did you get the updated presentation I sent?
Yes.
This one, okay. Just wanted to make sure. It might be easier if I go ahead. Can you share screen and let me control it?
I don't know how to let you control it. Do you want to share it directly, or?
Okay, let me yeah, I'll share it. Hold on. Let me.
Okay, I just made you co-host.
Okay, sorry. I'll go ahead and I should be able to do it from here. Okay, last time that I was with you all, I shared a lot of data, and I'm going to go back. Sorry, let me escape out. I'm going to go back and give you some information that was based on some questions I got and was asked to bring back and give you briefly some more data, but I really want to get into sharing with you all the actual direct programs and activities we're doing to address that. But I was asked to give a relative perspective regarding other counties throughout the state in terms of where we fall as compared to those other counties. So I want to go back up to syphilis. What you'll see on this particular map is the different counties in California, and you to the left have the number of cases, and on the right is actually the case rate. And so I've starred where we are, our county, where we land within the state. And what you'll see is that we obviously are one of the highest counties in the state for both the case rates as well as the number of cases. And so in this case, dark purple represents 100 or more cases, and a rate of 20 per 100,000 or more is where we actually fall. And so when you're looking at comparatively other counties, just below us, you'll see San Joaquin actually has a large number of cases. And then you start going towards the Bay Area where you have Alameda and Contra Costa, they fall similarly with that. And then of course, when you're looking at the southern part of the state, you're looking at Kern County, San Bernardino, Los Angeles, Riverside, San Diego. So we fall within the similar numbers of cases and rates as the other counties within the state, particularly the medium-sized counties. So this is primary and secondary syphilis cases. Specifically, if you look at where we are ranked, you'll see that we are 7th in the state in terms of our incidents, and that would be behind San Francisco, Shasta, Yuba, Butte, Trinity, Kern, and Sacramento falls 7th within that number. I'm going to scroll down, show you this also. Of note for us is looking at the state in terms of who's impacted by the primary and secondary syphilis cases. It still is primarily a disease that is contracted more frequently by the MSM population. However, if you'll look at Sacramento, and I'm sorry, I'm going to move my, I can't, sorry. Hey, I can't see the actual, oh goodness. I apologize, my screen is covered up by the gallery. I'm trying to move it over so I can see. Okay, sorry, so sorry. So when you look at Sacramento, one of the interesting things about us as compared to some other areas in the state, and then also central and northern also show that we have more, we're trending to have more female cases than you may see comparatively in other regions of the state. Like, for example, if you look at Los Angeles, you'll see that their numbers among women are smaller proportion than our cases among women. And so this makes a particular issue when we're looking at our congenital syphilis cases and our cases among pregnant women. When we have more women who are contracting syphilis, obviously, if they're within childbearing age, that results and the potential that there'll be more congenital cases in our area. So I wanted to share that. Sorry, let me go to the next. Let's scroll down. This was information that I gave you, and you all are welcome to go back and look at the data. I think Liz will share the I apologize, so sorry. So when looking at gonorrhea cases, what you'll see here is that we actually fall fourth in the state in terms of our incidence rates. Again, San Francisco tends to be the highest in all of these charts that I'll be showing you, but Sacramento falls fourth in this particular case. And that means we're above Los Angeles in terms of our incidence rate. Again, this is just a map showing California, the rates and the cases, so that you'll see where we land comparatively to the rest of the state. This is a particular one related to the incidence rates among youth aged 15 to 19. And so you'll see again, we have some of the highest incidence rates within the state. And then I'm just gonna go to chlamydia. Chlamydia, again, wish I had better news. Now, let me say this, I'm saying I wish we had better news because it looks like we're doing poorly related to our cases. However, it may not just simply be because we're doing more poorly in terms of preventing infection in our community. It actually could be also a byproduct of us having really good testing efforts where we're getting more people screened and identified. Remember that many of the STDs are actually asymptomatic, particularly when you're looking at chlamydia and gonorrhea. And so the fact that we are showing the incidence rates that we have, it really may be a reflection of us doing a really good job with our community partners to get people to actually come in and get tested and screened. So, you know, looking at this rate, I want to put that in context and say that that doesn't necessarily mean that we're doing horrible. It could be a reflection of us doing some really good efforts within the community in terms of getting people identified.
Do you and the other counties collect data on the number of tests administered, run on these to look at that?
So we as a jurisdiction can look at the number of tests that we perform because we have ways to keep it, but the way CalReady is set up, which is the reporting database where we get where the labs report cases and where providers report cases, and then where our surveillance staff use that to guide their efforts. That does not collect testing data. It only collects positive cases. So it's always been a lot of conversation around the state about whether or not they wanted to actually have that system collect tests performed. However, it really is not very, it would require a lot more work on a lot of people's size just to have that data there. So we collect it locally in terms of our testing activities. What we can't collect, for example, I can't tell you how many tests Kaiser may have performed, or I can only tell you how many positive tests may have been captured in a particular health system or institution. So yeah, it's challenging for us to actually, that's why I said it could be versus being able to tell you, you know, exactly this is the number of tests we've done versus another county. So yeah, it's a little hard to keep a handle on those exact tests because we don't have the systems. We're not connected to the other health systems that actually report cases. And we only do so much, you know, testing among our contractors and within our programs. When you look at chlamydia, we fall third in the state relative to Kern and San Francisco, with San Diego being behind us. So I just wanted to give that data. Farla asked me to show some things that show where we fall comparatively to the rest of the state. So I want, are there questions now or?
I'm not seeing the chat.
Okay, I just want to make sure. So just want to give you an update on our programs and actually what we are doing. I started off last time, or at the end of the meeting last time, showing you a little bit about how our funding is structured. What I want to highlight here is that this chart that is showing the different funding sources and the funding amounts, this chart is including about 8 new funding sources that we have gotten over the past 2 years that we didn't have in the past, that are bringing a significant amount of funding to our local efforts. When you look here, you'll see that we are the recipient of what is a federal initiative called Ending the HIV Epidemic, and the various federal agencies, including the CDC, HRSA, SAMHSA, primary care services, they all distributed money through different processes for counties that are represented in 48 jurisdictions that were identified across the country that represent 50% of all new HIV cases across the nation. And so we were included as that. So essentially we were invited to apply for these funds. And what you'll see here is we got both funding, we got funding from the CDC, HRSA, as well as a CDC component that was specific to doing integrated care within STD specialty clinics. And then you'll also see we got money from SAMHSA. I forgot to label that as an ETE, but it's an Ending the Epidemic funding. So we were very successful in actually securing funding across the federal funding streams for the Ending the Epidemic effort and initiative. And so those grants have been a real add to our services and has allowed us to move forward with expanding some of our program services. We also newly received from the state some congenital syphilis money specifically to address some of additional efforts for impacting congenital syphilis, and I'll talk a little bit more about that. So, you know, this has been very different. 5 years ago, our funding was about a third of what is here now. And so we do have a lot to work with to try to address some of the numbers that I showed you. And so I wanted to describe a little bit more about what some of those efforts included. What we were able to do with those new funds is secure 4 new communicable disease investigators, 1 new senior CDI. So we now have a total of 8 CDIs, which actually has doubled the number of communicable disease investigators we have. We were also able to secure 2 new senior health program coordinator positions. 1 serves as the sexual health clinic manager, and the other serves as the program manager over both HIV and STD prevention, as well as HIV and STD surveillance programs. We also were able to secure an additional health educator to support efforts within the Ryan White program. We have a health educator assistant position that is working as a linkage to care coordinator. We had 2 new medical assistant positions for our sexual health clinic and a new public health aide position that will serve as a community health worker within the sexual health clinic. We still, with the positions that we still have some positions that have not yet been filled. One is a nurse practitioner, additional medical assistant, and we also have a pending CDI and or senior CDI, which is for some new funding that we just were notified of, but we haven't secured, I haven't signed the contract for. But these are just showing you too how much those funds were able to assist us with building our capacity to do the services we are doing. So just to describe a little bit the Ending the Epidemic funding activities and what we're doing programmatically with those funds. I do want to shout out that today is World AIDS Day. This year marks the 40th year since the first cases of HIV were identified in the US. There is a program this evening at the Clooney Center in McKinley Park. If anybody wants to come at 6:30, they'll be doing a program and a kind of like visual. But for the Ending the Epidemic funding that we received from the CDC, what we're funding is a project we're calling Wellness Without Walls. And what that entails is doing testing and treatment services for HIV and STDs in a mobile health unit. When we first wrote this grant, along with 3 other jurisdictions in California that received this funding, we're one of 6 jurisdictions in the state that received this funding. We requested to purchase our own mobile van unit. And for some weird reason, even after a year of signing contracts, at some point the CDC realized that they're okay with us getting our mobile units, but because they are funding the state of California directly, who then filters the money to the 6 jurisdictions that were eligible for this funding, they were not, they said that the state had to purchase the vans for us because the contract was with them. But state CDPH procurement made the decision that they could not purchase them for us. And so we went, over a year of planning and getting this project together and having approval for all the interventions, only to learn that we were not going to actually be able to purchase the mobile unit. As it turns out, primary care was in the process of securing their mobile unit. And we were aware of that because the person that's now in the operations of managing operations in the clinic used to be one of my staff. And so I reached out to them and said, hey, is there any way we can partner with you all and do still go on the mobile unit with primary care staff? We have the same target populations that we're trying to outreach to. And so they, Dr. Mishra, thankfully said yes. And so we're just waiting for them to secure their mobile unit, which was scheduled to arrive at the end of November, which now we're in December. So I don't have a status, but it should be here shortly. So with that, we'll be going out to different venues, particularly venues where unhoused are located, because we are seeing a lot of cases of syphilis among the unhoused population, and that is one of the focus of primary care's efforts for their mobile clinical efforts. And so we'll be going out with different outings with them, providing the medical assistant and working with their providers to actually do the screening and treatment. We'll also have a communicable disease investigator that will be going out with the van as well, and that is funded under this grant to actually do the surveillance and interviewing activities and contact tracing activities with those patients identified as being positive for chlamydia, gonorrhea, and or Hep C on the mobile unit. So that we're excited about that project, and we really feel like, you know, again, the title Wellness Without Walls, we said that because we, you know, want to take it outside the walls of the clinic and really go to where people are, so that we can potentially address some of the access issues that still remain within certain populations. We also, under the CDC, got the Ending the Epidemic Component C, which is specifically to address integrated STD and HIV services within STD specialty clinics. That funding in particular promotes us providing more opportunities for diagnosis of STDs and HIV, but also promoting services such as PrEP and increasing our capacity to provide PrEP services. So we've already had a PrEP navigator who works within our clinic to help navigate people to pre-exposure prophylaxis, which is, I think most of you may know, but is the medication protocol that prevents HIV infection. And so we have quite a few people that were already on PrEP. This grant is allowing us to add an additional navigator, as well as support time to have a linkage to care coordinator that can help link the folks not only to STD services, but if they have primary care needs or need to be linked to insurance, that staff person will help them to identify what they need to do to be get linked to insurance. And so that both of these grants are for 5 years right now. There may be a possibility that it'll continue after that, but we're excited about moving forward with both of these projects that will impact clinical services outside within the community, as well as within the walls of our sexual health clinic. Our Hearsa funding is what is allowing us to now provide HIV care services within our sexual health clinic. That funding specifically is for Ryan White services with the target populations of the unhoused, but also transitional age youth, where we're starting to see an increase in HIV cases. That entails, again, providing treatment services. We started back in the late spring, actually seeing patients. We have about 30 HIV patients being seen now. It has been limited because the clinic has been, we were supposed to be having a build out that actually expanded the number of exam rooms that we were supposed to have, as well as additional areas for providers. Unfortunately, that was delayed over this past year because of COVID, having challenges getting contractors secured. And then our facilities had a contract with a construction company, and they pulled out at the end of June or end of July, August. And so we just recently received word that there is a contractor that they've secured to actually complete the build out. And so that's been one of the biggest barriers, because we can't promote our HIV services as much as we want to, because we don't have the capacity to actually serve more than what we're currently serving right now because of the limitations of our exam room. So we're doing as much as we can to try to expedite, that process. We do want to hurry up because we are having an official site visit from Hearsa coming in February, and they will be coming out to California for the site visit. And so we're anxious to get that moving. And so hopefully, the construction process will move forward. But, I expressed my frustrations and I was like, gosh, I'm the granddaughter of a contractor, and I watched my grandfather build houses, and it's taken a year and we haven't even knocked down a wall. And all it is adding, 4 exam rooms, knocking down a wall, and then throwing up a couple of more walls to actually create 4 exam rooms. But anyway, we're moving forward. We're going to be optimistic that that'll happen. And then when that does happen, we will be able to expand our services. So just to give you a little bit of.
Can I just interrupt for a second, Stacy? There was a question about.
I'm sorry, you didn't see it.
No, that's fine. Is the funding that you had on the last slide from for per year or for 5 years? So
all of this?
No, go forward. That right there, the ending the epidemic. So the CDC and the Hearsa.
Yeah. So the funding terms are 5 years. However, because there is a priority for a goal that the federal government has set for themselves to basically end new infections by 2030, we're anticipating that we'll continue to get this funding after this 5-year term.
So the fund,
yes.
So the 797,000 is for
That's annual.
Annual. Okay.
Yes, so annual. So each year,
okay,
we're getting that. Each year we get the 240 for the component C, and each year we get. Yeah, actually, I'm so sorry. I didn't make a correction. This now actually is $1 million. We got the second year we got a bump up in our allocation, and we're actually getting a 1 million a year for the Hearsa ending the epidemic. I totally forgot to correct that. So we actually got additional funding.
Stacy, can I interrupt just a bit? I did want to point out that the Public Health Advisory Board did help to support us with securing the funding for the build out, because we did have some administrative hurdles, and FAB wrote a letter to the Board of Supervisors to support this, and it was prioritized. So all the supervisors, especially Supervisor Notoli and Cerner, have been very supportive, and they keep asking to make sure that we prioritize funding for this build out. So wanted to point that out because FAB at several points has been there to support us. Stacy mentioned the number of staff that we have and are getting. And I was just thinking that 9 years ago, we were actually down to 1 CDI. And again, it was FAB that helped to write to the Board of Supervisors to actually request additional positions, including being able to get an STD controller. So again,
and my position actually.
Yeah, and Stacy's position too. So just wanted to point that out.
Yeah, and so last time I thanked everybody last time, because you all were very instrumental in not only the build out, but just securing the staff, because as some of you remember, we were getting pushback. Even though we had the funds, we weren't being allowed to put forth the positions. And so that letter that you all sent, along with some other of our community partners, really helped us. So yes, thank you again.
We are always happy to help in endeavors to help you all do your job better.
Very much appreciated. So I just want to show you a little bit of the strategies and how comprehensive our approach is in terms of how we're looking to address that. And so we look at one of the things that has happened, particularly what my position was created for, was to actually integrate our various programs and make sure that they were working together. So we used to have separate HIV and STD surveillance. So we had CDIs that did just HIV. We had CDIs that just did STDs. our CDIs now do both, so they don't separate. So if you have someone who ends up with syphilis and is co-infected with HIV, they're not going to have to be responsive to two different CDIs. That one CDI can do that. In addition, our prevention, our Ryan White program, and our surveillance programs were all in separate buildings across the county. And so what we were able to do a couple of years ago was get into the same suite. And so now they're all located within the same office, and the managers of those programs are in the same office, where they are able to really work together. We really work as a team and a unit. And what that has done is really built our capacity to follow someone through the continuum of services. So what that means from our prevention staff who do testing, and the contractors that, the subcontractors that do the testing services in the community settings, it's allowed us to more quickly link them to surveillance and follow up by our CDIs. Those that are identified as positive are more quickly linked to care, particularly for HIV. If they qualify for Ryan White, it makes it very easy for them to be navigated to those services. And so we really look at what we're doing is addressing the full continuum of from prevention through care and treatment, but also it has helped us to re-engage people who have fallen out of care. So for example, our Ryan White program, if they identify someone that's in their program who fell out of care for some reason, if they're not able to identify where they are, or if the person's at another provider, or if they've just simply fallen out of care, they can work with our surveillance and CDIs to go and locate that person to help re-engage them in care. And so our programs are really working very seamlessly. And again, they look at each other as units. So we have even our cubicles, we have CDIs sitting next to health educators, sitting next to the manager, just outside the manager's offices of all three programs. And so it just really has worked very well for us. And so what you'll see is just some of the things that we've been able to do, which is increase the number of people that we are testing. So this past year, we tested about 1,500 people, and that's with us and 2 subcontractors. But we also provide testing supplies and processing lab services for what we call our HIV test partners, which are not our subcontractors, but we fund them to actually participate in doing testing activities. And so our prevention staff works with those funded agencies to actually coordinate testing efforts within the community. Go ahead.
Can I interrupt for a second?
Yes,
and I was wondering if there are other questions as well. People should chime in because I know people have questions and it's getting a little late. But I wanted to ask you, with the new mobile unit, do you have any estimates of how many more tests that you can administer?
No, I can't really tell you that. We have some goals that we've set, but it really is going to depend on how many outings we're able to do and where we're going. But I do feel that it's going to significantly increase the number. I'm anticipating that it would probably double the number of tests we're currently performing. And so that's what our goal actually is to get around 1,000 people tested in the mobile unit annually. So with those testing services, you have to remember too, they'll be, treated on site as well. And so that just like a clinic, there's only a certain number of people you can screen and treat over a course of a day. But we're hoping that we're at least increase it by 1,000 additional.
Yeah, that's terrific.
Tests in a year.
Yeah, And of course, these will be people who are hard to reach. So that's phenomenal. Thank you. Steve had a question. Stacy, you provided some statistics about the 15 to 18-year age group and STDs. What is your group doing now to educate and hopefully prevent disease? Most of your efforts are addressed to testing and treating. Yeah, that was an area.
Yeah. So let me go ahead and go forward a little bit. So when you look at if you look here on this chart, when we look at prevention and education, what we are doing, we actually have we also are a recipient of the CalPrep funding, which is not pre-exposure prophylaxis, but is a program with the MCH division of the state. And that CalPrep grant specifically is addressing prevention for HIV and STD prevention and pregnancy prevention for youth. And with that project, we see about 300 youth annually. These youth are particularly vulnerable youth. They are youth that are attending schools I'm sorry, my brain just they are youth at continuation high schools throughout the city, the county, as well as youth within juvenile hall. So we do the workshop series with juvenile hall youth, as well as youth at Wind Youth Center. And so that is specific to the CalPrep funding grant. We also do education through different media efforts for the youth population. And so through social media and other efforts, we are promoting prevention messaging within the youth populations. We have a youth advisory board. So I'll just go ahead and pull this up. So we have a youth advisory board that we convened this past year that has about 25 youth that are being trained to be peer educators. And so they are someone that we're accessing to disseminate some of this information. And again, we do various media promotion efforts on social media platforms that youth frequent. And so those are some of the prevention activities that we are doing specifically with youth.
Terrific. Are there more questions? I know you had, is that the end of the presentation, Stacy?
No, I was just, I just wanted to go to that slide just so I could kind of show a little bit of that. And then I just wanted to identify like the coordination and community partners that we're doing a lot of our efforts with. So Harm Reduction Services is one of our subcontractors for HIV and STD services. They've been, and hepatitis C screening services. They've been a long-term contractor and they continue to be, as well as Golden Rule Services. Harm Reduction Services, many of you know, target directly the intravenous drug using population, injection drug using population, as well as the unhoused. Golden Rule Services specifically targets communities of color, particularly men who have sex with men, or Latino and African American who are disparately impacted by HIV. And one of our testing partners is the center, as we call them. And we do fund them to provide some testing services. So we pay for testing supplies and processing of labs for HIV and STD screening efforts that they're doing. Sunburst Projects is one of our subcontractors. They actually are they received a new contract with us as part of the Wellness Without Walls project. They are, we have to give 25% of those funds to the community. And so they were successful in the RFP process we had this summer And so they'll be working with us on the Wellness Without Walls project, doing various testing and education efforts, as well as doing a media campaign targeting people with the message of you equals you. So making sure that people know that you know, being treated and having undetectable viral load will lead to them being unable to transmit HIV. So treatment as prevention is the messaging that they will be giving in their media campaign. And again, When Youth Services is one of our partners that we work with, along with our SACWISH group, which is our Sacramento Work Group to Improve Sexual Health, which is comprised by numerous community entities, including state and local school representatives. We have representatives from healthcare systems on that body, AIDS service organizations, STD prevention organizations, clinical service providers like Planned Parenthood. So that body is very active. We have about 45 participants who continue to participate on that body to help us coordinate and get messaging out related both to prevention, testing, and care and treatment in our community. So I did want to, this was the time for questions, but there was a question, I believe, Sarah, you may have asked, I think you were the one who asked me about the treatment cascade last time.
Yeah, that was me. Thank you.
Yeah, and so the treatment cascade is also known as the care continuum. And essentially what that cascade is supposed to reflect is how many people, their goals in terms of how many people should know their HIV status, how many people are linked to care within a 30-day period from diagnosis, and how many people are in medical care. And the definition for in medical care is receiving at least one viral load or CD4 test within 12 months, as well as retained in care. And the definition of that is, and I'm telling you these definitions for a reason, because it's going to explain some of the numbers here, but the definition for retained in care is defined as people living with HIV who have at least 2 or more visits per year with at least 3 months apart during a 12-month reporting period, and then virally suppressed, which means the number of people obviously who are testing, who are virally suppressed, have a viral load of less than 200. So when you look at this graph, what it shows is where we are nationally, where California lands, where our TGA, which is our transitional grant area, which is us as our county, as well as El Dorado County, and Yellow's not part of our TGA, but we do count them in terms of the services that we provide. So
we're just
yes.
about overtime now.
Okay, I'm sorry. So this treatment cascade is just to show you what these goals are. What you'll see here, even though it looks like we're not doing a good job of linking to care for white services, it is partially because of this definition. So it's challenging because if someone is linked to care, that measure is a result of our Ryan White provider actually putting in the data that tells us how quickly they were linked and showing that viral load test. And so we've had a data backlog with one of our major Ryan White providers where they haven't entered those initial data, so it made our numbers fall. So this number is actually better than what that looks like. What I want to point to, just to quickly show you though, is that when you look at our Ryan White program, we do tremendously better at ensuring that our patients are able to achieve viral suppression. So look at us compared to the national level, as well as the local level, our county as a whole. Our clients who are receiving Ryan White services in this jurisdiction are doing better at their viral suppression outcomes. And so that's something we're very proud of, and we think is reflective of the very comprehensive wraparound services provided by Ryan White. And so, Sarah, I don't know if you have a question. I know I'm over time, but if you had questions about this graph chart.
Maybe we can follow up online. I think just understanding the really the denominators that are in here would provide more clarity. Lots of questions, lots of great observations, and thank you for your efforts, and especially today on World AIDS Day, an important data to be discussing these. Thank you.
So, yeah, I want to thank you too. It's quite appropriate to have your presentation on this day, and thank you for being here. I know it wasn't the best day for you in the end, so we really appreciate it. And I hope that Sarah can reach out to you if she has more questions, and you two can have a dialogue that we can then hear back from possibly to PHAB. So thank you so much.
Yeah, any of you are welcome to reach out to me if you have questions. I hope I was able to provide some of the answers to the questions you guys were looking for me to answer.
Very, very hopeful. Looking forward to having this infusion of funds and the mobile unit. Exciting developments. So thank you very much, and congratulations.
Okay, thank you all.
Okay. I apologize to the working committee. I have you on the agenda. You have a compressed time, but would love to hear an update from either Abby or Phil.
Sure, happy to give. I'm sorry if that's on there. A quick update. Not a lot has happened since our last PHAB meeting. We had a big push ahead of the last meeting to get the letter together and out. So thanks to everybody for voting on that, getting it out. We did confirm that a couple of the supervisors have read it. We are kind of doing an outreach process now to connect with each of the supervisors and get their reactions to the recommendations in the letter, figure out how to work together to move them forward. Had a great conversation with Supervisor Natoli right before this meeting today. We are working on getting back together as a working committee in the next week or two, I think, to figure out what our plan of attack is for the coming months. We have a number of different work streams that we've kind of identified and want to figure out how to make sure things can move forward in parallel. So I think we'll be looking at some work related to data sharing, transparency, and a dashboard, some work related to jail population reduction, alternatives to incarceration in connection to mental health services. And there's 3 or 4 others, or 3 or 4 other streams that might be areas of focus for us. So we'll be circling up in the next few weeks to figure that out, and may have more to say in January once we've kind of organized ourselves.
Sounds wonderful. And as always, thank you for the dedication and the time and effort that everybody on the committee puts into this. It's a wonderful, wonderfully productive committee on such an important issue. So thank you. Are there any immediate questions for the working committee? No? Okay. There is time on the agenda for public comment. As always, I encourage the public to ask questions during the meeting as well. So I'm not sure there's any others left, but I will open it up. Any public comment? Okay. Are there any questions from the committee or comments at this time? No. So I want to wish everybody a wonderful December, and of course, happy holidays at the end of close to the end of the month. I hope everybody has a terrific celebration of everything that's celebrated. So, we're into Hanukkah, and then there's Christmas and Kwanzaa and everything else that I would like to celebrate as well. So have a wonderful time. I wish you good health and happiness over the holidays. Thank you. See you in January.